Welcome to the deep dive. Today we're tackling a really fundamental topic, hypocalcemia.
Right. So simply put, that's when your calcium levels in the blood are lower than they should be.
Generally, we're talking below about 8.5 milligrams per deciliter. Yeah.
Exactly. And, it's easy to overlook just how vital calcium is. It's not just some minor electrolyte.
No, it's actually the most abundant metal in our bodies.
It really is. Someone once made a joke about us being like calcium-reinforced cyborgs because of our skeletons.
Huh. I like that. And thinking about where it all is, the vast majority, like 99% of it, is locked up in our bones.
Yeah, mostly is this stuff called hydroxyapatite calcium phosphate, basically. Gives bones their strength.
So that leaves just 1% elsewhere, and that's split, right?
Right. About 0.99% is outside the cells in the blood, the interstitial fluid, and then this tiny, tiny fraction, like 0.01%, is inside the cells.
And that tiny intracellular amount is, well, it's surprisingly critical. Too much is actually bad news.
Very bad news. High intracellular calcium actually triggers apoptosis-programmed cell death.
Wow. So the cell works pretty hard to keep those levels low then?
Immensely hard. It spends a lot of energy actively pumping calcium out.
How does it get in the first place? Through channels?
Yep, mainly two types. You've got ligand-gated channels opened by, hormones and neurotransmitters.
Okay.
And then voltage-gated channels which respond to electrical changes. You find those mostly in muscle and nerve cells.
Makes sense for excitability and getting it out. You mentioned pumps.
Yeah, ATP-dependent pumps, basically using energy directly, and also sodium-calcium exchangers. Plus, inside the cell, organelles like mitochondria and the smoothie arc can kind of soak it up, stir it temporarily.
Okay, that's intracellular calcium tightly controlled. What about the stuff outside the cells in the blood? The 0.99%.
Right, the extracellular calcium. It's roughly split 50-50 between what we call diffusible and non-diffusible forms.
Okay, let's break that down. Diffusible first.
So diffusible calcium has two subtypes. First, and this is a really important one, biologically active. Free ionized calcium.
That's the K2 plus ions just floating free.
Exactly. This is the form that does all the work. Neuronal action potentials, muscle contraction, hormone release, blood clotting. It's involved in so much.
And its levels are super tightly regulated, presumably.
Oh, absolutely. Then the other diffusible type is complexed calcium.
Complexed, meaning it's bound to something.
Yeah, ionically linked to small negative molecules, things like oxalate or citrate. These complexes are electrically neutral, and they don't participate in those cell processes we mentioned.
But both free ionized and complexed are small enough to diffuse, hence diffusible.
Correct. Their small size lets them potentially move across membranes, even if the complex form isn't biologically active.
Got it. So what's the non-diffusible calcium?
That's the calcium bound to proteins, mainly albumin, which is negatively charged.
Ah, so the calcium ions stick to the albumin.
Right, and because albumin is a big protein, this whole complex is too large and too charged to cross cell membranes easily. So like complex calcium, it's not directly involved in those immediate cellular activities.
Okay, so we have free ionized doing the work, complex just kind of hanging out, and protein bound also hanging out. How does the body know how much free ionized stuff there is?
Great question. The parathyroid glands have these special calcium sensing receptors on their cell surfaces.
Ah, sensors. What do?
They detect changes in the extracellular free ionized calcium levels. If levels dip even slightly, these receptors signal the parathyroid cells to release parathyroid hormone, or PTH.
PTH. Okay, that's a key player. What does PTH do once it's released?
It has a three-pronged approach, really, to boost calcium levels. First, it acts on the bones, stimulating them to release stored calcium into the blood.
Okay, tapping into the reserves.
Second, it acts on the kidneys, telling them to reabsorb more calcium so less is lost in the urine.
Conserving what we have.
And third, PTH stimulates the kidneys to produce the active form of vitamin D calcitriol, or 1025-dihydroxycholine calciferol, if you want the full name.
Active vitamin D, and what does that do?
Active D then goes to the gut, the intestines, and significantly ramps up the absorption of calcium from the food you eat.
Wow, so PTH triggers bone release, kidney saving, and then better gut absorption via vitamin D. That's quite a system.
It's a really elegant feedback loop to maintain calcium homeostasis.
And all this keeps that extracellular calcium in a pretty narrow range, you said.
Yeah, normally between about 8.5 and 10 milligrams per deciliter. Total extracellular calcium, that is.
But wait, you mentioned total calcium? Can that be misleading because of the bound forms?
It absolutely can. Total blood calcium includes the free ionized, the complexed, and the protein-bound calcium. And things like blood pH and protein levels, especially albumin, can change the balance.
How does pH affect it?
Well, albumin has sites that can bind calcium. In alkalosis, when the blood pH is high, albumin becomes more negatively charged.
Okay.
So it binds more calcium. Right. This means you could have a normal total calcium level, but the amount of free ionized calcium, the active stuff, could actually be low because more of it is stuck to albumin.
So symptoms of low calcium despite a normal total level on the lab report.
Exactly. And conversely, think about low albumin levels, hypoalbuminemia.
Less albumin means less stuff for calcium to bind to.
Right. So your total calcium might measure low simply because there's less non-diffusible protein-bound calcium.
Yeah.
But the hormonal system, PTH and vitamin D, might still be keeping the free ionized calcium level perfectly normal.
And that's called pseudo-hypocalcemia, false low calcium.
Precisely. That's why if you see low total calcium, especially if the patient doesn't have typical symptoms, you absolutely need to check the albumin level and ideally measure the ionized calcium directly.
Crucial point. Okay, so let's move on to true hypocalcemia, where the ionized calcium really is low. What causes that, broadly speaking?
Two main categories, really. Either not enough calcium is getting into the blood or too much calcium is leaving the blood.
Makes sense. Let's start with not enough getting in. What stops it?
Well, the big one is problems with PTH, hypoparathyroidism. Either the glands aren't making enough PTH or the PTH isn't working properly.
And why would that happen?
Several reasons. Probably most commonly, accidental removal or damage during thyroid or neck surgery.
Surgical complications?
Yeah. Or autoimmune disease attacking the parathyroid glands. Sometimes congenital problems like DeGeorge syndrome, where the glands don't develop right. And interestingly, magnesium deficiency.
Magnesium, how does that fit in?
Magnesium is needed for both PTH secretion and for PTH to act properly on its target tissues. So low magnesium can effectively cause hypoparathyroidism.
Good link to remember. Okay, so problems with PTH. What else stops calcium getting into the blood?
The other major player is vitamin D deficiency.
Right, because we need active vitamin D for gut absorption.
Exactly. So if you don't get enough vitamin D in your diet, or you have malabsorption problems so you can't absorb it from your gut.
Or not enough sunlight.
Or not enough sunlight for your skin to make the precursor, yes. Also, liver disease like cirrhosis can interfere with the initial step of activating vitamin D.
And kidney disease, since the kidney does the final activation step.
Chronic kidney failure is a big one, yes. The kidneys can't produce enough calcitriol, the active form.
Okay, so hypoparathyroidism and low vitamin D are key causes of not enough calcium in. What about too much calcium leaving?
Again, kidney failure plays a role here too. Damaged kidneys might not be able to reabsorb calcium effectively, so you just pee out too much.
Okay, increased excretion. What else?
Tissue injury is another category. Think severe burns, rhabdomyolysis, that's rapid muscle breakdown, or tumor lysis syndrome, where cancer cells break down quickly.
What happens there?
Dying cells release a lot of phosphate into the bloodstream. Phosphate loves to bind with ionized calcium.
Forming calcium phosphate.
Exactly, calcium phosphate, which is insoluble. It precipitates out, effectively removing ionized calcium from circulation.
Okay. Any other scenarios?
Acute pancreatitis can do it too. Inflammation releases free fatty acids, and these can bind with calcium to form, essentially, soaps, insoluble calcium soaps.
Wow, soaps, okay.
And one more, clinically important, large volume blood transfusion.
Transfusions, how?
The citrate used as an anticoagulant in blood bags is a chelator. It binds or chelates ionized calcium, turning it into inactive complexed calcium. So massive transfusions can temporarily lower active calcium levels.
That's a lot of potential causes. Now, what actually happens in the body when that free ionized calcium level drops too low? What are the effects?
The main effect, the one that drives most symptoms, is on nerve and muscle excitability, specifically neurons.
How does low calcium affect neurons?
Normally, calcium ions outside the neuron kind of sit near voltage-gated sodium channels and help keep them stable, less likely to just pop open randomly. They raise the threshold for firing.
Okay, like a stabilizing influence.
Right. When extracellular calcium is low, that stabilizing effect is reduced. The sodium channels become hyperexcitable. They're much closer to the threshold, much easier to open.
So the neuron fires more easily, less stimulus needed.
Precisely. Increased neuronal excitability.
And that leads to
tetany. Those characteristic involuntary muscle contractions and spasms. That's the classic manifestation of hypocalcemia due to this nerve hyperexcitability.
Okay, tetany. Are there specific signs we look for? For exams, maybe?
Absolutely, two classic signs. First is Chvostek sign.
Chvostek. How do you check that?
You tap lightly on the facial nerve, just in front of the ear, below the cheekbone. In someone with hypocalcemia, because those facial nerves are hyperexcitable, you'll see a twitching of the facial muscles on that side corner of the mouth, maybe the nose or eye.
Okay, tapping triggers the twitch. What's the second sign?
Trousseau's sign. This was maybe even more specific.
How does Trousseau's work?
You inflate a blood pressure cuff on the patient's arm above their systolic pressure and keep it inflated for about 3 minutes.
So, cutting off blood flow?
Essentially, yeah. The ischemia, combined with the underlying hypocalcemia, makes the nerves in the arm even more excitable. This triggers a carpopedal spasm.
Carpopedal spasm.
Yeah, if the wrist flexes, the fingers extend at the main joints but flex at the knuckles, and the thumb adducts across the palm. It's sometimes called the obstetrician's hand posture.
Got it. Chvostek's and Trousseau's. High-yield signs. What other symptoms might someone have?
Besides the obvious muscle spasms or cramps, you can get tingling sensations, especially around the mouth. That's perioral paresthesia. Sometimes abdominal pain or cramping. And in really severe cases, the hyperexcitability can even lead to seizures.
Seizures, wow. Okay. So diagnosis is mainly based on finding that low blood calcium level, right? Below 8.5 milli-GDL generally.
That's the starting point, yes. But always remember to consider albumin levels and check ionized calcium if there's any doubt about pseudohypocalcemia.
Right. Are there other tests? Maybe an ECG?
Yeah, hypocalcemia can cause changes on the ECG. The classic finding is a prolonged QT interval.
Prolonged QT, what?
It's mainly due to a lengthening of the ST segment, the plateau phase of the cardiac action potential. Calcium influx plays a role there.
Okay, so prolonged QT. Anything else?
You can potentially see arrhythmias, sometimes dangerous ones like torsades de pointes, or even atrial fibrillation in susceptible individuals.
So definitely something to check. And what about labs to find the cause?
You typically order a panel. Definitely PTH level, vitamin D levels usually, both the storage form 25-hydroxy and the active form 1025-dihydroxy. Albumin, as we discussed. Phosphate levels are important. Often they move inversely to calcium, especially with PTH issues, and magnesium levels because of that link to PTH function.
Right, putting that whole picture together helps figure out why the calcium is low.
Exactly. Is it PTH? Is it vitamin D? Is it kidney failure? The pattern of results points you in the right direction.
And treatment, what's the goal?
The main goal, especially if someone is symptomatic with tetany or ECG changes, is to get the calcium level back up safely and reasonably quickly.
How do you do that?
Usually with intravenous calcium, often calcium gluconate is preferred as it's less irritating to veins than calcium fluoride. For less severe or chronic cases, oral calcium supplements are used.
And vitamin D if that's the problem.
Absolutely. If there's a vitamin D deficiency, you need to replete that as well, sometimes using active vitamin D formulations if kidney function is impaired. And of course, treating the underlying cause, whatever it may be, managing kidney disease, correcting magnesia, etc.
Okay, so let's try to quickly recap the really key points. Hypocalcemia means low free ionized calcium.
Right, that's the crucial bit. Often caused by issues with the main calcium regulators, PTH and active vitamin D.
This low calcium makes nerves and muscles hyperexcitable,
leading to tetany, muscle spasms, cramps, perioral tingling. Remember Chvostek's and Trousseau's signs?
And potentially cardiac issues like a prolonged QT interval.
Diagnosis starts with measuring calcium, but remember albumin and ionized calcium. Treatment involves giving calcium, maybe vitamin D, and fixing the underlying cause.
It really is amazing how many different systems have to work together just to keep this one ion in balance.
It truly is. You got the parathyroids, kidneys, gut, bones, skin, all talking to each other hormonally just to manage calcium.
Yeah. And considering how many things can disrupt it, kidney failure, gut problems, inflammation, even transfusions, it makes you really appreciate that constant balancing act the body performs. Kind of makes you wonder, doesn't it, what other seemingly small imbalances might be having wider effects we don't always immediately connect.
That's a fascinating thought to end on. The interconnectedness is just profound.
Well, that wraps up our deep dive into hypocalcemia for today. Thanks for joining us.